So the next couple of slides basically just kind of go over the different formulations of opioid drugs that exist. And what we've kind of done here is we've kind of distributed them basically based on their potency. So this table summarizes the strong opioid agonists. And so basically morphine, hydromorphone, oxymorphine, fentanyl, methadone. These are the drugs that are really indicated for, severe pain. And so all of these drugs basically have abuse potential. There's different formulations of these drugs. Fentanyl is really kind of the most potent. And you see the comments here, use only in opioid tolerant patients. And so a patient that's naive to any type of the opioids basically couldn't handle fentanyl in most normal situations. And you can see all these different formulations that are here. IR refers to immediate release, and so it would be basically a tablet or a pill that basically gets distributed as soon as it gets into the GI system. Controlled release would offer kind of an extended duration of release, and so the pill or the tablet would be encapsulated, basically to reduce the effects of stomach acid and to kind of slow down the absorption process. And so the LADME process that we talked about way back in the beginning of the curriculum would be basically severely kind of restricted. Methadone and buprenorphine, which are used to treat opioid dependence, are not typically detected on a quote-unquote routine opioid drug detection. This would be a urine test. You have to require or get a specific test to detect these drugs. Both methadone and buprenorphine are partial agonists, and so you see them used primarily to treat opioid use disorders. Methadone, of course, is long-acting. You can see it kind of preventing the withdrawal symptoms for a day or longer. There can be reduced cravings. You can see a reduction of the euphoric effect. But of course, this drug is regulated in different capacities, and there's a lot of commonalities between methadone and obviously the drugs on this list, other opioids and so forth. And so these are the strong opioids. Here are the mild to moderate opioids, and so here's your codeine, your hydrocodone. These are your Vicodins and your Tylenol number 3s, and these are indicated for mild to moderate pain. And then as you kind of approach the pain scale, you can kind of transition from maybe Vicodin or hydrocodone to a drug on the previous list, depending on the patient. Codeine itself is a weak analgesic. Hydrocodone is often combined with acetaminophen or other NSAIDs. And there's various formulations that exist within that realm. Oxycodone as well can be combined with acetaminophen or other NSAIDs. And one thing to kind of keep in mind is that all these drugs do have abuse potential, and a lot of these drugs are formulated with Tylenol, and so the patient should be reminded that the Tylenol is already, or the NSAID is already in the tablet, and so they shouldn't be co-administering these drugs that are on this list with over-the-counter Tylenol, even in low doses. That can be problematic because that can really overdose them on the Tylenol side and be a big problem for them in terms of their overall liver function. And these are the kind of the mixed acting agonists or partial agonists, which are kind of like antagonists. And so pentazocine, budafenol, buprenorphine, and the indications are listed here. So, kind of the second, third line agent for different types of pain levels. These mixed compounds were actually kind of deliberately developed kind of with the intention of reducing the abuse potential, as well as kind of ameliorating the major side effect of respiratory depression that's associated with opioids. The analgesic components to this have the potential for less respiratory depression than the full opioid agonists, which were the drugs on the previous list. And there's a much lower abuse potential, though there's still an abuse potential. It's much lower. Um, there are some psychomimetic responses that have been associated, particularly with hallucinations associated with pentazocine, but there's limited analgesia and propensity to precipitate withdrawal symptoms. And so these have really kind of diminished in terms of the clinic. Oh, excuse me. Diminished in the clinic over the years. And so you don't see them quite as often. Buprenorphine is partial agonist. It's got a very high affinity to the mu receptor, and it can compete with a full agonist at that receptor. So it's used in the treatment of opioid use disorders. It can precipitate a withdrawal 6 to 12 hours after the last dose. The methadone, of course, is longer. Naloxone has poor bioavailability sublingually, which is typically how buprenorphine is given. The combination is used to prevent people from abusing this drug by crushing the tablet and dissolving them for IV use. Naloxone will precipitate withdrawal because it is an antagonist, of course. So interesting pharmacology on all of these. Drug interactions with opioid analgesics, the sedative hypnotics, the benzos and the barbiturates, you can see enhanced or increased CNS depression. Some of the antipsychotic tranquilizers, such as haloperidol or chlorpromazine, you can see increased sedation. You can see variable effects on respiratory depression. And then with the monoamine oxidase inhibitors, there's a high incidence of coma, basically associated with these drugs. And so when you combine any of these drugs with the opioids, there's an increased risk of death or coma when these drugs are used together. Hyperpyrexia would be a high fever coma, FYI. Other conditions that you should be aware of is both hepatic and renal diseases. Both of these disease states can affect the pharmacokinetics of opioids, as well as diseases with compromised respiratory function. So patients with emphysema, patients with really kind of severe COPD, maybe even really severe asthma, severe obesity. These are very important things to remember in terms of managing patients with opioids. Of course, head injury as well. We want to make sure the patients don't have any traumatic brain injury or head injuries. And then the asthma component is really specific only to morphine. I should point that out. And then, of course, persistent hypotension. Opioids have many adverse effects. We can kind of divide them into kind of the short-term versus the long-term effects. And so with the short-term effects, you can see kind of this rush. And so you associated with the rush phenomenon of opioid use, there's some skin flushing, dry mouth. There's a very nice kind of euphoria that's basically saying all is well with the world. And then, of course, initially you can see dilated pupils. However, then the short term is kind of, we can kind of summarize some of these short-term effects into the nod, where you see a little bit of tranquility and drowsiness or sleepiness. Their mental function or their mental state is beginning to get clouded. The pain is becoming suppressed and just basically goes away. And then obviously on top of that, the allowance of respiratory depression. And so this happens with kind of the short-term effects. Long-term effects are a little bit more damaging. Obviously, in terms of the central, there's some brain rewiring that can lead to addiction, intolerance, or dependence, all of which we'll define in a few minutes. It does have effect on the heart. It can alter heart lining and valve physiology. There's some circulatory problems as well. Liver, of course, we've already mentioned. And of course, the big one, respiratory depression, leading to kind of persistent pneumonia. Other drugs that kind of fit into this lecture include methylnaltrexone, which is an antagonist to the mu-opioid receptor, and it does not cross the blood-brain barrier, and so it's kind of a perfect drug for the treatment of this OIC, which is this new term that's associated with opioid-induced constipation. And so, this opioid endemic or crisis that's kind of been really prevalent in the news lately, now has kind of given birth to another group of drugs that are specifically there to treat opioid-induced constipation, which is now, now it's a thing. The other drug that we had talked about a long time ago was loperamide or Imodium. This is an agonist at that mu receptor. It doesn't cross the blood-brain barrier, and because it's constipation promoting, it's a great treatment for diarrhea. And so in terms of an opioid overdose, the three things that you really have to look for is coma, respiratory depression, and pinpoint pupils. Those are kind of the three hallmarks of a patient who's showing up acutely with an opioid overdose. And we'll end it right there because we're getting up about 11 minutes, and we'll continue this lecture and finish it up in the next video.